happening?
What's happening?
Not much.
How are you today?
Tired, but I'm all right. How you?
I've been good. Busy day, still working. I be working late, so I'm multitasking though.
Yeah, I got all type of multitask stuff I'm doing right now. I got a lecture to give in the morning. I got a flight to catch tonight. Still got to leave work. I got stuff.
That's
But
what's up.
nonetheless, talk to the people for a little bit.
Yes, I'm gonna watch the clock, so we're gonna do an
Yeah,
hour.
yeah, maybe even a little less. Cause I gotta get out of here. So we'll
Okay.
see how it goes.
All
All right.
right.
So let's get it cracking. Go ahead.
You want me to intro or you?
Go ahead. Just go ahead.
All right. Hey, everybody. So, if you've been here before, welcome back. If it's your first time, I'm Cola Red. This is Doc P. I'm actually one of his patients. I had surgery last year. I'm a year post op, and I shared my whole journey on social media, all my doctor's visits, researching, finding the doctor to do my procedure, everything. And people started asking me a lot of questions about my journey and even questions for me to ask my doctor. So instead of me at every office visit having a list, we said, why don't we go live every month? So this is free game Thursdays.
Pre-game Thursday. I was telling
So
people.
you can ask questions three different ways. So people submit questions to me, and then they watch later. People, if you want to ask a question during the live, there's a question mark at the bottom of the screen with a bubble around it. Place it in there so we can screenshot it and roll it over if we need to. And you can also request to join. And we're doing a short one tonight. So if you got a question, go ahead and get it in there. All right, so I'm gonna start off with a submitted one. Oh, I'm sorry.
Well, thanks
You,
everybody for congratulations on new practice.
yeah, that's what I
Um,
was gonna say. Do
long
you want to kick it
time.
off with that? Cause
Yeah. So finally, long time coming. Like it was just a lot of just red tape, and it's just a lot. But it worked out as promised. So the reason why is because again, when you try to help your community and stay in your community, is always more difficult, right? So it's much easier for me to go up north, mess with commercial insurance, but that's just not me. That's not what I set out to do and what I plan to do. So I'm working out of Mount Sinai Hospital. I'm still at Ingalls too, so I'll be operating at both of them. The clinic is through Mount Sinai on the west side of Chicago. Yes, it's on the west side of Chicago. But with that being said, I have the autonomy to do what I want to do. One beautiful thing about the clinic is that there's no patient turned away. Absolutely no patient turned away. So if you don't have any insurance or whatever insurance you had, you can at least come and see me there for cheap. Like even for people that don't have any insurance, it's like $60 for a visit. All right, to see me in person. And then for surgeries, it's super affordable too. That's if you have no insurance. So don't be like, oh, I'm coming in here. No, it's for people who don't have insurance. For them, if you do have insurance, it's a different story. But it is a NFP hospital that looks out for everyone, which is why I joined, because while I'm here in Chicago, this is what I plan on doing. It ain't gonna be all.
that's stop saying that while I'm here.
We family. It's like what Drake say. I'm not here for a long time, but a good time. So
I'm still working on you on that one.
when it's over, it's over. So y'all better get these cheap free surgeries while you can. But yeah, I'm here to serve the people. I got a lot of people I need to operate on. I got a lot of people that have hit me up. Like again, I have put the number out. I can't do nothing else. I accept everything. Everything. If you have the insurance, if you're in Illinois, you pretty much can be, you will be seen. So if the answer to the question is, do you accept? Yes, I do. So call the office. I put the number out there. I'm going to do it like I promised, for the entire week. I'm going to put it out there. After that, I'm not answering no more questions. What's your office? It's there. It's there. I cannot answer it any more than that. It is already there. Share it. That's the thing about us. Like, we'll have, if you're in New Jersey, same difference. So you can telehealth me. I still have my own telehealth service, docforthestreets.com, or well, you can do the telehealth, and then if you need surgery or what have you, we can plan for you to come to Chicago to have surgery, right? If you have no surgery in New Jersey, guess what? The same rules apply as if you have no surgery here. The hospital will work with you the exact same way. So all my people that are in Canada, Africa, that have called me or what have you, this is like the perfect opportunity. I am here to be able to operate. So take advantage. I'm here. I put it out. I can't make myself more available than I am right now. This is the best that I could do. So I hope people share it. You got a woman suffering from fibroids, any pain or what have you. That is what I do. That's my wheelhouse. So share the information. That's it, people.
That's what's up. And since you brought up insurance, do you want to talk quickly about open enrollment in Illinois?
It's
I
open
know you
enrollment.
posted it, but I
I
didn't
try to
share
tell
it.
you.
I think it needs to be
It's open
repeated.
enrollment pretty much everywhere. Like, again, so I don't care. They probably, man, somebody can probably come after me. I don't give a damn. Look, insurance company make billions of dollars off of you all, right? Off of us, period. No problems, right? It is nothing for you to utilize insurances to your benefit, right? So if you have horrible insurance or if you have out-of-state insurance, you need to come in and fly to see me. It is just get a year. Just put it in your mind that I got to get a PPO plan for 6 months to a year, however long that they put it that you have to have it. It may cost you about $2,000, $3,000 for the year. So be it. If that's the case, and you get a $20,000 surgery for getting a PPO plan for the year, that's what you want to do. So now that it's open enrollment, I don't want to hear nobody say like, "Oh, I just don't have it," or "I don't have insurance." This is the opportunity to do it. You can switch your insurance to whatever you want to. If you have public aid, I'll tell you right now, Meridian is horrible. County care is horrible. If you have an option, like do a Blue Cross Blue Shield Family Health, even do straight Medicaid if you're in Chicago, do those. But yeah, some insurances will pay for flights and hotels. That's really, really designer insurance though, but with that being said, like, you have options. Look into selective enrollment, ask them, like, if I go to a certain state and I want to, just that they don't have to know what you're doing. You just be like, I want what the best plan possible that I can go anywhere to get care. And they have to list out those plans for you. Yes, instead of the $300 or $400 you pay for a month, it may be $500 or $600 a month. However, think about it. For that, and you need surgery, it's an investment that's well worth it.
Absolutely. All right. So, first question in the chat tonight. What is your opinion on the MyFembury pills? Are they successful?
They are, but they are for women with fibroid disease that are kind of in between. If you are having significant fibroid issues and you're having significant bleeding, yes, absolutely, MyFembury is a option to help you with your bleeding. MyFembury is not a medication that you could take forever and ever, amen. So don't be thinking like, oh, I'm gonna be able to take this medication, and if you need surgery, it's going to allow you to run away from surgery for 10, 15, 20 years. You can take it for 2 years. That's about it, right? So then at some point you have to look into definitive treatment for your fibroids. Endometriosis is another indication, absolutely, for patients with endometriosis. MyFembury, Orlissa, excuse me. Orlissa is another one. Those are two competitors, but that will help with pain with endometriosis. So yes, I do believe in the medication. I don't push the medication. They show not cut me no check right now, so I'm not pushing it, but I offer options. It is an option if you are suffering from fibroids or endometriosis, and you need like immediate answers. It's a good medication.
And when you say it helps with bleeding, it does not shrink fibroids. It just
No,
helps with bleeding.
it helps with the bleeding, right? So it is not something that's going to zap your fibroid and make it not magically shrink and disappear. It's not going to do that. You may have some very minimum reduction of fibroids. You may not, as far as the size is concerned. But that's not how it's working. It's not designed to shrink the fiber. It's designed to control where you're bleeding from, which is your endometrial lining.
All right. What is better dealing with pain from periods? Is it ibuprofen, Tylenol, or Midol the best relief?
Ibuprofen. Ibuprofen. So pain from periods comes from a prostaglandin release, right? Prostaglandin are inflammatory molecules that are released when you have pain, like when that cause inflammation. So if you can stop the release of prostaglandins, it helps significantly with the pain. And that's why people get confused. It's like, oh, I'm taking ibuprofen and it's still not helping. Well, one, you have to take ibuprofen before that prostaglandin releases. So if you know you're about to come on your period, to start to take the ibuprofen before and schedule it, not like, oh, I'm feeling it. But if you start feeling it and you take ibuprofen, you already lost. You want to start taking it before your cycle, start taking it 2 days before your cycle, and then take it every 6 to 8 hours throughout, the first few days of your cycle. That's how you beat it. You can't wait to day 2 or 3. It's like, oh, my cramps are so bad and now I'm taking ibuprofen. No, it's going to help some, but it's not going to really do what you need it to do. You need to do it before the prostaglandins release.
Can you ask your physician to prescribe muscle relaxers for period pain? Isn't your uterus a muscle?
No, that's not how it works. So when you talk about muscle relaxants, that's usually for like back muscles, right? So your back has spasms, and those muscles can spasm, causing nerve pain, just from the spasming of muscles. So those muscle relaxants will relax those muscles. It is true that the uterus is a muscle, but the pain is not from muscle spasming. The pain is from inflammatory molecules that are releasing. The pain is from buildup of blood in the lining or the cavity of the uterus trying to expel out. So imagine you're trying to like squeeze ketchup out of a bottle, and you're trying to just shake it up, trying to squeeze it out. Well, you're still trying to squeeze it out, get it out. It's kind of similar to what your uterus is. It has this blood that's in there, and it's just trying to shake it up and get that blood out of there. And a lot of times those clots and things are in there, and it's preventing it from coming out. So therefore, it's going to cramp harder to try to get that blood out, and that's what's causing you to have pain. In addition to the cytokines that are being released, that are causing you this causing inflammation. So to stop that release is how you counteract it. You're still going to have cramping, but the pain from cramping is more so from going to be helped with ibuprofen. The muscle relaxants are not going to do it for you.
All right. Next one. What level of
Put y'all questions in the chat though, because like we can't really see them as y'all putting them up real time. So if you got questions, put them in the chat so we can answer them.
Yeah, put them in so if you just joining, put the questions in the bubble with the question mark, because the screen scrolls and then I can't see it anymore. What level of pain should your cramps be at? When is the pain above a normal level?
When you can't function. Like if your quality of life is significantly hindered, you can't go throughout your day-to-day functions, and you are, in misery from cramping. That's not normal. Like you should not have that. Cramps should be uncomfortable, but they shouldn't be to the point where you cannot function. When they get to that point, then that's a problem. We need to figure out like what's happening.
And I don't know why I dealt with that for years and years.
I don't know you, man. Yeah, you on something different.
I'm a superwoman.
You're different. You're way different. I promise you, I'd have tapped out so long ago.
All right. I think TT. Okay. I think they're saying tummy tuck. I had a TT and with muscle repair. That's tummy tuck, right?
Mhm.
Okay. Will I still get my fibroid removed without damaging the results of my tummy tuck? Can I still get my fibroids removed?
Depends on how big they are, and it depends on who you go to. That's all I can say about that. I would. I mean, you can't go back and switch it up. But if you are thinking about cosmetic surgery, i.e., tummy tuck, and you have significant fibroid disease, it is so much better and easier if you do that before you get your tummy tuck. You want to get the fibroid, the thing that you need the most, which is the fibroids removed. Do that first, then do your tummy tuck after that, because this is what a tummy tuck is. Legitimately, this it is cutting. It's like taking a cookie cutter, cutting around your belly button, and then taking the skin from there and pulling it down, cutting the bottom of it, and then sewing that cut section down to where the other top of the other section used to be, and then taking a new hole, putting your belly button through that and sewing up the belly button. So now you got to imagine from a if you're getting fibroid surgery, especially a myomectomy where you got to go in there, you can't just go. You're gonna have to go back through that incision, right, to go and get the fibroids. Or even if you take laparoscopic surgery, now you got tight skin, you still got to pop holes through them to get instruments in there. It's just a mess. I mean, it's done. I've performed myomectomies as well as hysterectomies on patients that have had tummy tucks before, but you better know who you're going to, because it can be problematic. If you're gonna do that, make sure you know who is doing your surgery. Do your research.
All right. A lot of period questions. Is the period on birth control a real period or withdrawal bleeding?
It's a real period, right? So when you're on birth control, um, basically you're simulating what your normal cycle would be without it actually happening. Because that's why when you take birth control pills, you have a placebo week, right? And you stop the pills for that week. It's basically trying to simulate what you would normally how your body would normally produce hormones, but your body's not normally producing them. They're suppressed. You're actually giving artificial hormones, tricking your brain to believe that your ovary is doing it when your ovary isn't doing it. It's this artificial stuff that's actually keeping these levels at what they are, and it's stopping your ovaries from producing the hormones, which then in turn, which is the important part, it stops you from ovulating, right? So you still have the menstrual bleed, you just don't have ovulation. So it's a true period, but it's not an ovulatory cycle, meaning that um, you're not ovulating in between your menstrual cycles. That's what you're stopping with birth control pills. When you look at like Depo-Provera or progestins, that's a little bit different. Um, it does kind of inhibit ovulation, but you still can ovulate, but it's working more so on the lining of the uterus. So it's a little bit different. But birth control pills, anything with estrogen in it, it is tricking your body into believing your ovaries are doing something that they're not.
All right. Can a fibroid sit on your bladder?
Yes, it can, and it can decrease the expansion of your bladder, and it can cause frequency of urination. So that's one of the things that we call bulk symptoms of fibroids. In which, yes, it's a hard object that could push on your bladder and cause you to have frequency of urination.
That's a funny one. I saw a celebrity on Twitter say that they had a 9-pound fibroid from years of relaxing their hair. I thought you said in a previous video they don't have true root causes for fibroids. I said it was funny.
It is.
I get a lot.
So I'm gonna tell y'all, like I always say, I say what I say. I back up what I say. I stand behind what I say, and I'm gonna say it in this situation. I said what I said. People can fix their mouth to say anything. Again, people have their own understanding. Just like I argue with this fool all week because I'm a fool myself for arguing with people that sit up here and try to tell me about different herbs and sea moss and don't eat meat and your fibroid, it'll stop the fibroid from coming. They don't know. Okay, these are people that have never operated on a fibroid, never had a fibroid. I've literally in these hands right here, I've had thousands of fibroids in these hands right here. So how can you trust somebody who's never even held a fibroid in their hand, right? Or never even studied it, have absolutely no idea about fibroids, right? They have no idea. It's basically people, which I understand when you naturally try to make sense of things that you just don't know about, right? Like we're not lawyers, but we naturally be like, man, he going to jail if you do that, or you going to jail if you do that. You don't really know the law, but you think that if somebody does this, that the sentence may be this, or you think that if this happens, then this happens. Like engineering, like I think this works this way for that, but I've never constructed anything or built anything to know if that's really how it does it. It's the exact same thing with medicine. Yes, you would think that it has to be the diet. It has to be if you don't exercise. It has to be you eating this, or it has to be perms or what have you. So if that's the case, why isn't everybody with a perm walking around with an 8-9? First of all, I've never seen a 9-pound fibroid. Okay, all right. You had huge fibroids, and you can still have worth of 9 pounds worth of fibroids. Okay, it's like that's just people just be talking. They don't be just be talking, just be talking. So yeah, don't listen to celebrities talk about medicine. Just like you
Yeah.
wouldn't listen to me talking about what's happening in the celebrity world. I don't know. I'm a doctor. I deal with what I stay in my lane. It's the problem with people not staying in their lane. It's everybody else trying to be a doctor. You're not a doctor. It's like I cannot be a lawyer because I'm a doctor. So if everybody stayed in their lane and we start trusting people that actually know what they know, we'd be better off.
All right, the next question is from the chat in the screen. I had a stroke on blood thinners and don't want any kids. Which procedure is best for me? My fibroids are large, 13 centimeters.
I mean, that's a tough one. I would have to know more information to say which procedure is best for you. But if you have a 13-centimeter fibroid and you don't want children, then off top, the number one option for you would be hysterectomy. Now, how you do that hysterectomy, it depends on who you go to. Like Cola, I would do it robotically or laparoscopically, which would get you out of the hospital quicker and recovery time quicker, given the fact that you also had a stroke and those types of things, like or blood clot, or stroke, whatever
She
she wrote.
said I had a stroke from blood thinners.
So with that being said, I want you off the table.
On blood thinners. It don't
I
say
want,
from. It says
right,
on blood thinners.
I
Sorry.
want you off the table. I want to get things moving along. I would do a robotic hysterectomy. That would be me. Everybody is not going to be comfortable doing a 13-centimeter fibroid laparoscopically. I could tell you right now, a whole bunch of people are not going to be like that. You're only going to find a few people. I'm not the only one. There will be some other ones, but there's not going to be a lot of gynecologists that are comfortable with that size mass doing it laparoscopically. But for you, if you are otherwise stable and clinically stable and not having residuals from this issue, a hysterectomy would be a laparoscopic hysterectomy would be the best option for you. But if you're not stable, having issues from everything else, then temporizing your bleeding or whatever issues you're having first, getting you stable, and then going to do a laparoscopic hysterectomy would be the best treatment plan for you.
All right. Uh, Next question in the chat, and maybe this is for me. Is it true after you remove your fibroids and your uterus, your stomach will get big? Absolutely not. I actually went to see my other doctor about earlier, and she was like, "Girl, you snatch. Give me your waistline." So my stomach is completely different. Now you do have to have really big fibroids for them to protrude. Mine definitely protruded. My stomach is still not completely flat, but it wasn't flat. I mean, it wasn't completely all because of fibroids. It was just my body type. I'm a curvy lady, so. But no, my waistline, my upper abs, all that is snatched. And I didn't have any extra procedures like lipo or anything like that.
If you remove a big mass, it should not make your belly blow up more. It just physiologically doesn't make sense. What makes your belly blow up is
Definitely.
so.
All right. This one says, Doc P or Cola. How do you research a doctor if they don't have social media? I can answer it too, but I'll let you answer from a doctor's
Go ahead.
perspective.
No, you go
Okay.
foundation
Since you be
perspective.
telling my age anyway, I'm not ashamed to say I was around before Google. but, but me personally, so I've if you watch my journey, you may already know this, but if you watch it for the first time, I have only had like two gynecologists in my entire life, and both of those were pre-social media era and all that kind of stuff. A doctor's education is usually public information. Um, you can more than likely, even if they don't have social media like Instagram or Facebook, a lot of them at least have LinkedIn, which has been around for a long time. So you can at least see what schools they went to. Even if they don't have a lot of reviews, if you find a doctor that meets the criteria that you want, like I look at where they did residency at, what hospitals they worked in, because in my opinion, if you just work at all good hospitals where everybody have good insurance, you ain't seen nothing. You ain't really seen nobody in crisis. You ain't seen nobody come when they close to death. So public information also is what demographics certain hospitals service. That's public information. So you can tell by what zip codes, what kind of people they're seeing without them telling you. And then last but not least, when you finally make an appointment with somebody that you actually like, it's an interview. Like you don't have to stick with them just because you went to see them one time. You
Right.
should actually interview them. Like, I mean, me and Doc P, the first time I came, he could tell I was nervous and he was like, "It's okay. We just gonna talk. Let's just talk." It's an interview. So you can still say, "I don't want to come back to this person," or you can keep going. And before social media, like the lady who delivered my babies, I actually asked her, "Do you have any patients that would be willing to talk to me? You can give them my number because I don't, privacy. Would you have somebody that could talk to me personally about how they were as your patient or your level of care?" And she was like, "Absolutely." And three people called me, no problem. So I don't think she was offended by it, but she definitely had people call me. So,
So yeah, if somebody want to join, I'll give them in a second.
oh,
So I echo everything that she just said. That is like spot on, hands on. Typically, they got a social media. Typically, they do. They got something. And a lot of people sleep on Twitter. People got Twitter. It's like, go to Twitter. Like, look at what they do on social media. And let's say, for instance, all right, they don't have social media. I agree. They do got a LinkedIn. Start digging. Start looking where they from. Looking, try to see peripherally in their personal life. Google search them. Um, and like she just said, also look at blogs, right? Women
oh
talk.
yeah, that's a
Women
good one.
talk. Women talk for sure. So even if they try to stay low key in social media, their patients are going to talk. If they, there's a group of patients in that area that have a group that guaranteed have opinions about every doctor. And then the biggest thing Nicola just said that's important is it's an interview. You go in there and you have a conversation. Just because you set up an appointment don't mean you obligated to anything. Your insurance paying for it. If you paying out of your pocket, that's $100 you spent is well spent. So you go in there and you have a conversation. If you feel uncomfortable, somebody's not answering your questions, they giving you bad vibes, they give you this, like, don't just lean on such and such and such and such and such said this person was no, you start to do your assessment. Now, mind you, if your mom and your auntie, everybody that went to them and had some type of report, you can at least kind of use that a little bit. But it is an interview. You know, if they have a bad day, they might have a bad day. You may need to give them another chance. But, you know, you going in there interviewing and you being choosy because it's your care, it's your life. So, you know, all of those things combined helps you get to the right doctor. The problem for us, we don't do that. We go to whoever that said, you could look here. I could pay for to look good on Google. I could pay to look good on Google. You know, it's not, don't go to Google. You see, oh, they got good reviews. They got 5 stars. Boom. Anybody can pay for that. You know, that's a trick bag. You need to go beyond, take it another step beyond that, right? Because this ain't just a car you getting worked on. This your body. This your life. So go take the extra mile and try to look at some of these people, and dig deep into them. Some of them have affiliations with parties and things that you would find probably quite interesting as a person of color. I had a lady hit me today that was, you know, she had some work done, and she looked through, you know, all of the pictures of like this particular doctor, and it was like 2 black people there, and like all the rest of them were Caucasian, and the 2 black people had the most horrible incisions. They had like incisions that were vertical. So it was like, out of all of these people, you're a cosmetic doctor, and like, why the 2 black people are the ones that look different than everybody else? So it's like stuff like that, where it's like research that have to be done before you trust somebody to care for you. And I try to give y'all as much game as possible. I can't go snitching on everybody. I can't do it. But I give y'all enough information to where you can read between the lines and see what is what. And it's whoever has like hit me up DM wise and asked me about particular, I don't tell you directly, but I tell you enough information to help you make an informed decision about whoever you're trying to see. Yeah, let's see what
All
it says.
right. Yeah, so I was gonna say, don't you got a request?
Yeah. Hello? I don't know what the,
Is the
yeah,
camera flip?
I don't know. It don't look like they wanted to be on here. Cancel. She may
All
be
right.
talking.
Next question. Can you please wait? Can you please explain what a shot cervix is, how it affect pregnancy?
A shot service?
It, yeah, it says, can Dr. P, PLW, but I think she meant please explain what a shot cervix is and how, maybe she means short cervix is
Sure.
and how it affect pregnancy.
Um, so some people have a condition that's called cervical incompetency, meaning that their cervix, for multitudes of
Okay,
different,
yeah, it was short. Sorry.
multitudes of different reasons, are just not very equipped when it comes to holding a pregnancy, and meaning that they can start to dilate early, or that they just, you know, can not sustain closure for long enough to keep pregnancies intact to viability. Um, so yeah, it's not so for those particular women. So those women, unfortunately, they find out usually when it's too late. Usually when they're in a pregnancy and they start to have dilation, you know, 20 some odd weeks really early, um, and have significant complications. And then it's moving on to the future where, you know, like things like cerclage, bed rest, those types of things have to be implemented into the pregnancy to help things, you know, move along and help her carry the pregnancy to fruition. But yeah, cervical incompetency is a really, really, really significant thing. I've seen it many, many times. And it's something that you definitely is another reason why you go get prenatal care, why you just don't be like, oh, I don't need a doctor and I just have babies at home, what have you. It's things like that that happen that can be managed during pregnancy, but have to have somebody that knows what they're doing to help manage it for you.
All right. Which one is better for someone trying to preserve their uterus and have children ASAP? A traditional myomectomy or the robotic myomectomy?
All right, so I'm gonna say this one to nauseum. I'm gonna say it again. So myomectomies, right? I am no longer a proponent, meaning that I don't perform traditional laparoscopic myomectomies. Robotic and laparoscopic are really the same thing. It's basically small incisions that you're making to remove objects out. I used to perform, I am a laparoscopic surgeon. I am a robotic surgeon. I do both of them. I do them for a lot of different things. Myomectomies, I no longer agree with. Reason being is because number one, when you do laparoscopic or robotic myomectomies, then you basically lose your ability to palpate or feel. If you don't feel, then you can leave fibroids behind, which can cause potential problems in the future. Second part is when you have fibroid surgery or major surgery to your uterus, you're obligated for a C-section in the future. So it doesn't make sense to do a surgery laparoscopically, possibly leave fibroids behind, and then in the future have to go back and do a C-section anyway, right? So that's my logic, my thought process behind it. Since I've been doing open myomectomies, I haven't had repeat people come back, and it's just because I'm very, very thorough when it comes to getting all fibroid disease or fibroid tissue out. So my recommendation, everybody's a little bit different. Some people do have like large, maybe pedunculated fibroids that are off of the uterus, but with those, there should not be a true issue with getting pregnant, right? So if you have pain or bulk symptoms from those, then in those situations, it's possible that you can get a laparoscopic myomectomy, but large in part, open myomectomies make more sense, but not vertical incisions, horizontal incisions.
All right.
Yeah, go ahead. I got to make this phone call real quick.
Okay. So let's go to a question submitted for me. What is life like after surgery? Any regrets? So no, I don't have any regrets. My life is definitely a lot different. So if you watch my journey before, I suffered really bad and for multiple years with heavy bleeding, extreme pain. My cycle would pretty much have me man down. So every month I was at least out of pocket for 2 to 3 days. The bleeding was initially about 7 days, but it decreased when I lost weight to about 3 days. But even with the heavy bleeding, when I wasn't in pain, it was heavy enough to where I would have to I could only like be gone short periods of time, like from my house, maybe 2 to 3 hours at most, just because I was always afraid of having an accident, or it's almost like you're afraid everybody's going to know your secret or whatever. So I just didn't like to be out. Now, as I said last week, fibroid free, I'm out as much as I want. I don't have to plan vacations around it. I travel for work. It's no problem. No accidents. I guess no regrets. I mean, I've had to buy new clothes because my waistline changed. I've had changes in just little things like you don't even think about, underwear size, belts. I had to go to cleaners and get loops added because they're too big now. So my life has definitely dramatically changed. I don't have any regrets. sometimes I am curious why I waited so long. But like I said, if you've watched before, I did a lot of research before I chose Dr. Johnson. So I am glad that I waited for it to be him because I was very scared the whole time. But I definitely trusted that he was going to give me the treatment he promised. Even if it was harder for him, he was going to do what made it easier for me. And sometimes you don't always get that when you're dealing with health issues or medical care. Sometimes the patient doesn't have a voice, and he definitely let me have a voice. So that was very good.
All right, my bad.
No, you're good. I just answered for me. Next question for you.
Vertical incision is not the only way. If somebody tells you the vertical incision is the only way, you need to walk out of their office. Nobody should ever say only to you. You always have options. That's not true. Just because they cannot do it doesn't mean that it can't be done. I hate when people do that. Like, don't let somebody just say, oh, it's the only way. Then you ask them, like, is there any way possible? And they be like, oh, this is impossible. If they say that, get up and walk out. No, or vertical incision is not the only way that you can have a myomectomy or hysterectomy for that matter. It's not true for that question. I'm sorry, but that just had to say something.
What was the question?
She said, I have been told that because of size and amount, a vertical incision is the only way. Are you saying that any size of fibroids can be removed via horizontal incision? Yes. I said it. Yes. That is what I'm saying. Yes. Horizontal incision can be done. Now, it might be a bigger horizontal incision. That might not be like some of the classic little horizontal incisions like I do, like for everything. If you have very, very large fibroid disease, I may have to make a larger incision, but it definitely does not have to go up this way. It doesn't have to, they don't have to. And if they don't know how to do that, all they have to say is that I'm not comfortable doing that, that it would probably be better for a vertical incision to do that, that you can accept. But if somebody's like, oh, it's absolutely no way, get up, walk out.
All right. Another question in the chat bubble is for me. Hi, Cola. What procedure did you get done? Did you go into menopause? So I had a robotic hysterectomy. I had my cervix and my uterus removed. I did not remove my ovaries. I am not in menopause. I am 43 because Doc P snitched on me already. So it was no reason for me to remove my ovaries or start menopause. Now, if I was older, maybe it would have been part of the conversation, but there was no reason. They were healthy and not abnormal or anything.
Absolutely.
All right. Another question in the chat. Uh, do all women go into menopause after a hysterectomy, even partial?
You just said it.
Yeah,
No,
no.
if you have your
And
ovaries, play it simple. You keep your ovaries, you're not going to menopause. But realize this, every woman is born to hit menopause at some point in life, whether it's naturally or whether it's surgically. It's going to happen. So the question is, will it happen early if you have a hysterectomy? No. You can have a hysterectomy, which is removal of your uterus, and keep your ovaries. If you keep your ovaries, you do not go into menopause. This is a fact. It's a big misconception. It's a lot of why. It's a big reason why women don't come in, because they believe that once you have a hysterectomy that you're done. Your ovaries and everything are not working. They're getting taken out. That is not the fact. All right. You know, these things, little thing right here. All right. Hysterectomy, uterus, cervix, fallopian tubes. These are your ovaries. These stay. These produce hormone. These do everything, right? At some point, these are going to fail. And every woman, they're going to fail at some point. But people think this is the most powerful structure in the whole body. No, it's not. It's these, right? The only reason you have one of these is to get pregnant and have babies. If you don't need babies or don't want babies or what have you, and you got these or what have you, you don't need this if you don't want them. If you want them, then you keep that. Other than that, these are the important things. They don't have to be taken if you take this.
all right. And a follow-up question says, well, what if you take one of the ovaries and not both?
Same thing. One ovary responds just like one kidney. It's not. You're still going to have significant hormone production. It's not. There's not going to be any change. No difference.
All right. Is local anesthetic given for IUD insertion?
No, it's not, because local anesthetic is not going to do anything for you. What do you localize? The best thing you could do for IUD insertion in the office would be to possibly give Cytotec, which will dilate the cervix to help insertion easier. But a local anesthetic doesn't fix everything, right? You know, IUD hurts because you're pushing this object through the cervix. For women that have never had babies and have not had any cervical dilation, sometimes it's harder to get that straw-like device through the cervix. So therefore, Cytotec will help dilate it. But when you talk about lidocaine and numbing up, there's nothing to numb. You can numb the cervix all day long. That's not the issue. It's pushing it through that cervix. So you can't numb up the whole cervix. So, you know, if it's extremely uncomfortable, then you can, you know, opt to have anesthesia or something for it, but that's much more expensive. It's just not as cost effective. But for those patients that, you know, have true troubles with IUD insertion, Cytotec, with Cytotec, before you place the IUD, it makes it a lot easier.
All right. So we at 15 minutes away from 1 hour.
Yeah, let's get like one or two more questions and call it a day for the day.
Okay. All right. Let me see in the chat. Oh, the person who wanted to join said sorry. I think their phone was freezing.
Okay.
So do you have a request for a join or no? Okay. All right. So I got all those in the box so far. So if you have questions and you want to submit, we'll be on about 15 more minutes. You can put in the box, but I have a list too, so I'll go back to the list. All right. Should birth control be prescribed to teenagers to treat acne?
It can, but that wouldn't be my first line to do that. It's not always just because she has estrogen content. It could be other different things. So I would highly recommend going to your primary doctor, and then possibly dermatology first before going to a OBGYN to prescribe birth control pills and just throw it at it, because it's other skin conditions and things that play a part in acne and skin conditions that dermatologists are much, much more savvy at dealing with, and they may not even, you know, savvy at diagnosing. Brother, everything is not from hormones. You know, some things are just not from hormone levels. So dermatology first, then if those preventative measures like the doxycyclines and clindamycins and some of the antibiotics and things that are used to clear up acne, if those things and topical agents are not clearing it up, then you could possibly think about birth control. But I wouldn't jump to that first. That's not first line.
All right. What is pill-induced PCOS?
Pill-induced PCOS? What pill are we talking about here?
I don't know. Not sure.
Yeah, I'd have to know a little bit more information. That's not a very common thing. Um, yeah, there are no birth control pill induced PCOS, if that's the question.
Yeah,
I,
they didn't
I
really say pill, and nowadays you do need to know what kind of pills they talking about.
yeah, I would argue against that, because birth control pills are actually one of the um, part of the treatment for PCOS, and they increase the sex hormone binding globulin, which helps bind up some of the free estrogen in the system. So, yeah, I'd have to know more about that. But if somebody just say, "Oh yeah, you have pill-induced PCOS," I'd have questions. They may not know the mechanisms of PCOS. Not to say it
Hmm.
can't happen, but it's not something that rings a bell to my ear. It's not very, very common, if you will.
All right. if I've had my ovaries removed, do I need hormone replacement?
Not necessarily. If you are premenopausal for whatever reason, you had your ovaries removed, then possibly. That means if you're like early 40s or what have you, and you far away from menopause and they had to remove your ovaries for whatever reason, it really kind of depends on what they had to remove your ovaries for. If they did it for like a breast cancer or something, then that may not, that won't be, they're doing it for the estrogen content. So giving you back estrogen is bad. The only time you really need estrogen is if you are premenopausal and you had, ovary issues, or if you're postmenopausal and you had significant symptoms or effects from being postmenopausal or lack of ovarian production. So you don't, so, all of that to say, it's not mandatory per se to just get hormone replacement therapy. You don't just give that back. It's a risk associated with that too. People that need hormone replacement therapy need it, but if you don't need it, you don't just give it freely.
Okay, so I'm gonna take one more because we'll be at 10 minutes now.
Yeah.
All right. All right. I have zero symptoms for my fibroids except looking about 4 months pregnant. I don't have heavy cycles. I don't have any pain. The doctor wants to take my left ovary because that's where they primarily are. I am reluctant to have surgery. Is it necessary at this point?
So just taking a left ovary because that's where you have where she's ovulating. Is that what she's saying?
She said that that's where they are. That's where they primarily are because that's where they primarily are.
Nah. Don't just take ovaries just to take them. If your pain is from ovulation, then you do birth control. But she's saying that's what they primarily are, which would lead me to believe that they come and they go, which would lead to me to believe that she's talking about ovulatory pain. And if that's the case, the answer is not to remove the ovary from ovulatory pain. The answer is to impede ovulation, which you can do through birth control.
Well, no, sorry, because it's on the screen and not in the thing. So I think she's saying she's not having any pain. She's not having any heavy bleeding. The
Mm-hmm.
doctor is saying it's because of location. And she said that she looks 4 months pregnant, but she
Oh,
doesn't
talking
have
about
heavy
fibroids.
cycles,
Talking about
no
fibroids.
pain.
Talking about fibroids.
She said my fibroids.
Yeah, fibroids. I thought she was
Yeah.
saying ovary. But if they're not giving you any issues or no problems, then you don't necessarily need to do anything. Unless they're extremely large. That's something that I would kind of need to look at your ultrasound to see. But if they're not giving you any issues, you don't necessarily need to do anything. So
Okay. She said I don't have pain. It's just they keep growing. The fibroids are growing.
let me see. Because if people be saying just about any, I had a lady today just called me, was talking about she's in her 50s and she had had a period in the 6 months, and she was going through perimenopause and was having some abnormal bleeding at the end, and she had fibroids, not big fibroids, 4 centimeters, not huge, and they were trying to do UFEs on her and do surgery on her, and I said absolutely not, absolutely not. And that goes for everybody that, oh, you're trying to butcher on people and you're just trying to cut on people. If you come to me the last thing I want to do is to operate on somebody that don't need me to operate on them. I don't want
Mm-hmm.
to operate. I operate to help people that need my help. If you don't need my help, I'm not getting a check. I am not getting a check to just cover you. Nah, I got better things that I could do to get a check that put myself at risk or you at risk by cutting on you when you don't need it to happen. I am only here to help people. That's it. And then the very last thing I want to say is somebody reached out to me earlier about tubal reversal. I don't know if she's in here or not, but I told her I would talk about it. If you DM me about specific stuff, this is your forum for me to be able to talk about it. I don't have time to talk to everybody about their questions, their issues, or what have you. I do these for those question. So when I say it, that everybody could benefit. But for the lady that wanted a question about tubal reversal, right? So here's the thing about tubal reversals. The reason why they're really not done and not many people do them is because they're not very successful. They have literally like a 15% success rate. You wouldn't do anything with a 15% success rate. Would you go to the grocery store if there was a 15% chance of you getting there safely? Or fly a plane if there's a 15% chance of you doing it? You just don't do it. All right. There's a much higher risk of you doing a tubal reversal and getting an ectopic pregnancy and having a problem, have to have a bigger surgery because of your desire to get a reversal as opposed to IVF. So the telltale sign of this is that reproductive endocrinologists who are fertility doctors, they don't offer, most of them don't offer tubal reversals. Why not? They don't do it because their money is based off of their success rate. So if they did a procedure that's going to lower their success rate, they would lose money. So they're not offering those procedures. That's why it's very hard to find somebody that does tubal reversals. People do them, but it's only a few people that will do them because the success rate is so low. So if you have had a tubal, if you go to 90% of in vitro fertilization specialists, or fertilization or infertility specialists, they're going to tell you to go through IVF. Just like I would do the same thing, go through IVF or in vitro fertilization, which means giving you medications, causing you to ovulate, going in, taking those eggs, removing them out of your body, taking them with your husband's sperm or donor sperm, whoever's sperm, mix them together, fertilizing them, taking a fertilized embryo and taking that back, putting it into your uterus, allowing pregnancy to happen. That's bypassing the fallopian tubes. That's all you're doing, right? Fallopian tubes are doing that for you naturally. If those are blocked or have a problem, now you have to artificially do that. Same thing. That's all it is. But don't every woman that had these tubals or whatever, you're wasting your time looking for somebody to do tubal reversals. I'm not doing them. Most people are not doing them. Yes, I think it's a couple people in Florida. There are some people that would do them. I would not invest my money that way. I would more so take that money, put it to IVF if that's really what you want to do, as opposed to getting a 15% success rate and over 80% chance that you may have an ectopic pregnancy or not get pregnant at all. Just doesn't make sense. Cool.
All right.
All
So
right.
well, 5 minutes away. So one more plug for where you at again?
I am at SMG Lawndale. It is a subsidiary of Mount Sinai Hospital. It is on 11th and Kedzie. The number, information, all that stuff, I have posted it. I'm going to post it all week long. So if you want to find it, it's there. The number is there. So don't hit me no more. Don't text me no more. I have now provided a number where there are paid professional people that are there to answer all your insurance concerns, scheduling concerns. My first day of clinic is 12/5, December 5th. From there, I will be in office every Monday and Friday. I will be operating for as many people that come that need surgeries. That's how much I'm going to be operating. So it's going to be a lot in this very beginning. I'm all for it. I'm ready to go. I have not really operated for real in about 5 or 6 months. I am hungry to get back into the operating room on my robot and all that stuff. That is my place of peace. So I am ready to go. But that is all the information. Call, set up an appointment. Great staff. Listen, my last practice, call, couldn't get nobody, didn't help you, whatever. That's why I left. That's why I'm out of there, right? This one, I will never have that happen again. I will assure you, from 9 to 4:30, if you call that place, somebody's going to answer the phone. We don't even have an answering service. A live person is going to answer you. So if you call, then that's why I'm there. If you call, they will pick up the phone and they will answer your question. They may not know all the answers, but they will at least have a live person there that will talk to you, help you set up your appointment, help you set up your surgery date, help you set up anything you need to do with insurance, all that stuff. It will be someone there to help you. That's why I'm there. And it's nobody is left behind. If you are underinsured, don't have insurance, come from out of state, whatever your situation is, at the bare minimum, you will at least have the opportunity to come in, see me, so that I can examine you and give you some type of direction and options of what it is to treat your